Hi, welcome to the second week of Consider This, the new webinar series that simplifies the public health and science of the pandemic. I'm Marianne McDowell.
And I'm Heidi Beidinger. And today's guests are Jeff Shorey and Brian Baker, who are scientists here at the University of Notre Dame, and they study immunology. We're going to be talking about immunity and vaccines today and what these concepts mean in the time of COVID. And we will introduce them shortly. But first, and as a reminder, the goal of our webinar is to help our community's understanding of public health and science as it relates to COVID.
We want everyone to understand the language that you hear in the media and that we'll be having conversations with our guests. So prior to each session, we upload short video tutorials and other information to help you understand the concepts a little bit. I'd also like to remind everyone that we have an email, consider@nd.edu. So please email us with questions and comments as they arise through the week. And we actually did get an email last week, and I'd like to read that to you. It's Alice Morris from Seattle, Washington, and she writes, "Thank you for providing such informative information about the biology of COVID-19. For a non-scientist, you made the science digestible. I have one question, however. If only one virus enters a cell and one virus gets out of a cell, how does the virus grow and multiply in the body?" And so thanks for asking that, Alice. When I made that tutorial, I just had one virus entering the cell and then one coming out, just as an example. But really what happens is the RNA multiplies in the cell and lots of viruses get out, and that's how it actually multiplies. So thanks for asking it. She goes on to write, "I was particularly moved by Provost Miranda's description of staying in the room, of how to engage in conversation with those whom you disagree. This advice is especially important given the current state of division within our nation. Thank you again, Alice." And thank you, Alice. I really appreciate it.
So did I. When we got that email, we were just thrilled because they were thoughtful questions, and I too loved the concept of staying in the room. So as Alice pointed out, we spoke with the provost last week. She was a guest on our show, and she discussed her new work around the COVID-19 Registry and her new initiative called The Moment to See and the Courage to Act. The registry is a public health tool to understand how COVID-19 is impacting the lives of people who are in our community, and it's open to all Indiana citizens, whether you are COVID-19 positive or negative or haven't even taken the test yet. So it's open to everyone. We have a link on our ThinkND page, and we encourage everyone to register. And if the provost is listening, Marianne and I are now both registered. So. Okay, so let's consider this week's data. Unfortunately, and then this is the more sobering part, COVID is not decreasing here in St. Joe County, and it continues to rise. So we have to remain vigilant about wearing our masks and doing social distancing, as well as hand hygiene. And then just yesterday, the state of Indiana reported a single-day record for new cases. There were 1,945 new cases in Indiana. And just to give you some context, when we were on lockdown in March, the high point was 946 cases. So at that time, we were all freaking out because we almost had 1,000 cases. And now, you guys, we are at double that number of cases. Oof. So yeah, exactly. Take a deep breath. So the state health officials are particularly, they're watching two places in the state of Indiana, and that is northern Indiana, which of course includes us, St. Joe County and Elkhart County, but also southwestern Indiana, which includes Pike, Posey, Vanderburgh, Du Bois, and Spencer. So we really need to be paying attention and wearing our masks. I also wanted to let you know that I'm going to be posting a weekly video where we are going to track the county data together. So from week to week, we can watch the trends, and then hopefully, if you have questions or want to discuss it more in depth, you'll send me an email, and then we can talk about it in greater detail on the show. So now let's move into the introduction of our guests and have our guests join us. It's like they're teleporting.
Nice, right on cue.
Welcome.
Hello, everyone.
We are so pleased to introduce our show's guests today, Dr. Jeffrey Shorey and Dr. Brian Baker. Jeff is the George P. Craig Jr. Professor in the Department of Biology, and his research interests focus on the pathogenesis of M. tuberculosis, infectious diseases, and drug development. His lab has ongoing studies to evaluate and develop a new class of antibiotics that show potent activity against M. tuberculosis. Brian is Reverend John A. Zahm Professor and Department Chair for Chemistry and Biochemistry, and his research is centered on his long-standing interest in molecular recognition in the immune system. His work focuses on types of immune cells called T cells that recognize antigens on abnormal cells, such as virally infected cells. More simply said, Brian is interested in how molecules interact and respond to each other. And as a reminder, molecules are the building blocks of a cell. So welcome to you both.
Thanks. It's great to be here, and thanks for having me. Really appreciate it. This is a great idea. The first time I heard it, I really thought this was wonderful. So I'll go ahead and tell you a little bit about what I do. So as Heidi mentioned, we work on Mycobacterium tuberculosis and other mycobacterial diseases. And probably for the audience that don't realize that over 2 billion people are actually infected with Mycobacterium tuberculosis. Fortunately, only about 5 to 10% of those actually come down with disease, but that still leaves about 10 million people who are have tuberculosis every year, and about 1.5 million people die of TB every year. So this is certainly a huge problem, and my lab is very much interested in dissecting the mechanism by which Mycobacterium tuberculosis causes disease, how it invades the body, and how the immune system is not able to control that. And as Heidi mentioned, we're interested in drug development and trying to find new antibiotics for that. But sort of the interest that I have, so related certainly to SARS, is we're trying to develop vaccines against tuberculosis. So I have a very long-standing interest in how you develop vaccines and how you can use them to fight infectious disease like SARS. So that's kind of my area.
Brian?
Well, yeah, thank you, Heidi and Marianne. This is a great concept. I'm really excited to be here, and welcome to everybody who's here to listen. So I'll give you a very quick background of what we work on. As you mentioned, Heidi, we study T cells and what we call T cell recognition, but it's really fundamentally, we ask questions: how does your immune system tell the difference between you and not you? Obviously, an immune response directed towards a pathogen such as SARS is what we're hopefully working towards nowadays. But fundamentally, that involves a bunch of complicated processes that we study in our lab. How does the immune system tell the difference between you when it shouldn't be recognizing you, and then something that it should be hopefully is recognizing a virus or some other pathogen? We study that from what we call a very structural and physical perspective. It involves just asking questions about how molecules stick to each other. More recently, there's been a huge explosion in the interest or the intersection between recognition of the immune system and cancer. So my lab has a large program in what we call cancer immunology or cancer immunotherapy, which is asking how can we understand, as we understand how the immune system recognizes targets, how can we steer that towards immune recognition of cancer? But one of the key things in studying the immune system, particularly with cancer, is just about everything we've learned in the immune response to cancer. We learn from immune responses to viruses. So they are in many ways, in the language of immunologists, a cancer is non-self, just like a virus is non-self. And so if we want to study an immune response to non-self, the principles and ideas are easily applicable from cancer to viruses to tuberculosis to other sorts of things. So fundamentally, that's where we are. Fortunately, we were able to pivot our research as this pandemic started towards quickly picking up our work on cancer. And we have a small project on SARS-CoV-2, T-cell immunology, leading towards some new ideas about vaccines.
Wow.
You guys, that's really awesome. I'm so excited that you guys joined us. I need to have a full disclosure to the people listening. Jeff and Brian aren't just guests. We've been friends for a long time. I've known them for 20 years. I hosted a baby shower for Jeff and his wife, and I hosted a baby shower with Brian's wife, Laura, for someone else. So we've been friends for a very long time. And even though Heidi and Brian are just meeting for the first time, I think you guys have a connection, like you know his wife, Laura?
Yes, I do. And it's so funny because when Marianne said, we're going to invite Jeff and Brian Baker, I go, oh, okay, I don't know Brian. And then later on, like a couple meetings later, she's like, oh, Laura and Brian Baker. And I'm like, Laura Baker. I'm like, I work with the Laura Baker. Who's that? Like, is this the same person? And then here we are now. Another small world story about all the connections that we have here in town. So, and Laura is wonderful, wonderful. She and I do community work together, and we actually served on the Granger Paths board for many years together. So anyway, it's great to meet you, Brian. And let me say also from those introductions, our audience is in for a treat because as you can hear from their introductions, they are the perfect people to come and talk to us about immunity and vaccinations. So let's consider the headlines, Marianne.
So I saw a paper this week in bioarchives, and so it was really assessing how the pandemic is affecting people's opinions about taking the flu vaccine.
Hey, and just if I could, before we go on, you're talking about bioarchives, and it says that the article hasn't always been peer reviewed, right? And so I just want to make sure our audience might not be familiar with this language. So if we could take a second to talk about what this means and why it's important, being peer reviewed or not being peer reviewed.
Sure, Jeff or Brian, you guys want to take a stab at what bioarchives are and what it means to be peer reviewed? We can
Sure, I'll take a stab at it, and then Brian can jump in, of course. So one of the hallmarks of science, really, and I think why it works different than many other fields, is that we use a peer review process to really check the rigor and the accuracy of the data that's presented in both grants and in papers. So it's a huge part to have experts be able to review that information that's present in the paper before it gets disseminated to the general scientific audience and also audience that aren't in science. The fact that these are not peer reviewed means that they haven't undergone that rigorous kind of analysis by experts in the field. I think that's okay. I think in this context, we need to get the information out there quickly. So having this mechanism to get it out there in a really quick fashion, because it sometimes takes months for a peer review process to work. So I think in this context, it's a good thing to do. But you have to be aware of the potential issues, and that is that it hasn't sort of undergone that analysis that peer review gets for you. But I would also say that as a person who I'm reading that article, I just need to keep that in mind and be my own critic of that data. So I'm all game for it.
So Brian, do you know, so it's in bioarchives, but then do those individuals submit to a different, like to a journal and have it peer reviewed, or does it just stay on bioarchives?
Well, it can stay on archives, but in general, the idea is that something that is timely and important might be submitted. A scientist might submit something to bioarchives to get it out there quickly because it's important and timely. Much of the early work in the pandemic was on bioarchives. And the idea is then people can look at it, but eventually that work will be submitted to bona fide scientific journal. We'll be going through peer review, and will be potentially the findings altered and conclusions changed a little bit as that peer review process goes on. But one of the things I think the bioarchive process has been, again, as Jeff said, you have to be very careful. You have to, anybody can submit anything to bioarchives, and so just because it's on bioarchives, it does not mean is something that you should take very seriously. You might want to, but early days in the pandemic, there was so much that we didn't know and so much that was important to learn quickly. I found myself looking at bioarchives on a regular basis, getting new reports, new things coming up, and generally based on, you can get a sense for the quality of the science by looking through it. You want to be careful, as Jeff said, about relying too much on bioarchives, but there is a trade-off between having that rigorous peer review and getting important data out there quickly.
Yeah, I agree with you. I think especially in a pandemic, it's important to get the information out there. I was thinking about that paper I told you about on bioarchives made me think of some other headlines that are in the news. Even today, there was one in the New York Times about the FDA putting out new EUA guidelines around vaccines. And so, Brian, can you talk a little bit about what is EUA, and let our audience understand that a little bit?
Yeah, so EUA stands for Emergency Use Authorization, and this is when so a normal therapeutic, a normal vaccine might go through years and years of study and various clinical trials, and we probably all heard the news reports about how early, the fastest I think previously a vaccine has been approved has been 4 years. And that really reflects the careful approach that scientists and clinicians take to new vaccines and new therapeutics. We're in the midst of a health crisis, and so there's obviously a great interest in accelerating that. So again, there's a trade-off though between how much in-depth study you can do and how rapidly you can get something out. So the FDA has rather rigorous requirements in place for ensuring safety. An emergency use authorization allows some of those to be looked at maybe, I don't want to say not safely, but allows some of that process to be skipped ahead a little bit or skipped over in the interest of public health, allowing something to be used when it otherwise might not have gone through all the various testing that we would do in normal times.
And Jeff, do you have any thoughts about the process and the recent headlines?
Yeah, so there's the convalescent plasma, and there's a few other examples where they've used this. And their guidelines are that there's data to suggest that the benefits outweigh the risk. So that's kind of how people at the FDA are looking at it. They think that the potential benefits outweigh those potential risks, but you don't know that for sure. And that's why, there's some caution about these approaches. But I would say, as far as the vaccines are concerned, and as Brian alluded to, 4 years has been the fastest this has been going through. And we're looking at less than a year, potentially, in having a vaccine. And I think there's a few reasons for that. We have put so much effort and so much, both from the government level, from academic level, from industrial level. In human history, we've never put so much effort into something like this. And I think that's in part the reason why we're pushing this as quickly as we are. I think it's also that the risks associated with developing a vaccine, and the reason why we go very slow about this process is it's very expensive to make a vaccine. So companies do not want to start putting money into the process until they're quite sure that the next step is going to be successful, or the previous step is successful. And the government is taking a lot of the risk out of it because they're providing billions of dollars to sort of help develop these vaccines. So you can go from clinical trials to developing large stockpiles of the vaccine at the same time. And companies normally would never do that because it's just too expensive if they turn out to be wrong. And it's like Brian also said, the FDA has a very rigorous process in line, and they certainly do so for vaccines. So when you have a vaccine that you want to potentially use, you get in the queue. You send in all your paperwork, it gets put in that queue, and the FDA will review it at some point. But sort of the analogy I was thinking when I was thinking about this is my son loves roller coasters, right? And we go to Cedar Point every year. And you have to wait in these long lines. It's really hot. I don't like it at all. So we learned about the Fast Pass. So the Fast Pass gets you to a much closer to the roller coasters, right? And we can get on them and faster and get on them and do the fun things, which is why you're there. And so if you're working on a COVID-19 vaccine, what they do is they put you in the front of the line. So the review process can happen so much faster, not because the rigor is not there, but because they're sort of saying, all right, we need this now, so we're going to put you in the front of the line. And I think it's important to say that all the mechanisms that are out there to push these vaccines are done so without sacrificing, at least we hope, not sacrificing the safety and the efficacy evaluations that you need for a vaccine. And so I think that's important to know.
Yeah, I love that analogy. I'm going to steal it from you. That's
So
perfect. It makes total sense.
Yep.
I just wanted to quickly, before we move on to the next section, I saw a question in the question and answer that's relevant to the thing about peer reviewed. And the point was, what does peer reviewed mean? So like, it doesn't mean that I call up my buddy Jeff and say, will you review my manuscript so that it gets accepted?
I wish it was that.
Yeah, sometimes I wish that too. What it means are scientists in your field, usually they're not like your buddies, that they review your work and try to make it better. So that's what peer reviewed means. But I think we should
and make it better and are very critical, asking the difficult questions and forcing us to justify our methods, justify our conclusions. So it's a really rigorous process. I just went through it. So this is why it's still fresh. The burn is still fresh, right?
Yeah, sometimes we complain a lot about it.
That's
for
right.
sure.
It's usually anonymous as well, so that removes some of the hesitation somebody otherwise might have to call somebody out on their work.
Yeah. But that doesn't stop us from trying to guess who it was.
Yes.
Done that.
All right. So should we go to rumor has it? Okay.
Yep, I think so.
And I think this one is perfect. So we gather these rumors from friends and family and our students. And this one is perfect for our guests today. So rumor has it that if you test positive for COVID, that you are immune for 90 days. Is this true? What do you guys think?
Well, Jeff, I'll run with this for a little bit and then I'll let you correct me as needed. I think that there's an awful lot that's really not known. So in a normal, there is no normal. The types of immunity that one has that we typically get after a virus or a vaccine, they vary. They depend upon the type of virus. They depend upon the type of vaccine. We don't really, I think it's fair to say, we expect that there will be some long-lasting immunity after if one gets infected with COVID and hopefully then recovers. It's not entirely clear how long that will be. Some viruses you do, and with some vaccines, you do wind up with lifelong immunity. Others you don't. Your immune responses, everyone's a little bit different, but you bulk up and then you kind of ramp down and you generate what we call immune memory, and the extent to which all of those things play out with different viruses, it just depends on so many things that we really don't know yet. And I think it is fair to expect that we can expect most people will have long-lasting immunity after exposure to this, because that's the way most immune responses to viruses work. But it's not entirely clear. One thing that is important to emphasize, we all get flu vaccines every year. One reason we get flu vaccines every year is because the flu virus mutates so rapidly, and there's so many different strains out there. And if you really pay attention to the details of a flu vaccine, they'll even tell you some of those gory details about which version of the flu you're vaccinating against. SARS-CoV-2, the virus that causes COVID-19, it is mutating. It does not seem to be mutating as rapidly and as in a significant way as the flu does. And so we might not, although again, it's very early days, we might not expect to have to get a new COVID-19 vaccine every year, but it's very early to really say that conclusively yet.
Yeah, so I agree totally with Brian there that it's really early to tell. We do have some data with viruses that are a lot like the SARS-CoV-2. So there was a SARS-CoV-1 that was around early 2000s. So they've had more time to study in those individuals who were infected, and they've seen pretty good immunity. So even 18 years later, they can still see an immune response against the virus. So that gives us hope that we'll see good immunity with the COVID-2 because they're really highly related. They're very similar viruses. But the question is does it matter on the extent of the infection? So if you had mild disease, do you have an increased chance of getting affected again? Versus if you have a more severe infection, developing a stronger immune response, are you going to be protected if you recover? And that's sort of the question that a lot of people are asking, is to say, does it matter how severe the cases were? And again, we just don't know yet.
Okay.
Can you guys talk a little bit about protective immunity versus sterile immunity? So go ahead.
And may I even just take us one step further back? Can somebody define immunity?
Yeah,
and then go to Mary Ann's question about sterile and protective immunity.
Yeah, so I guess I tell my students that immunity is defined as a response by the body to a foreign molecules or foreign components, and the process of using immune cells and the immune process to eliminate those foreign material. And I specifically mentioned foreign because most people think it's to microbes, viruses, bacteria and stuff, but the immune response can also attack artificial knees, artificial hips, if you have also transplant. So really the immune response is anything, it attacks anything foreign with the process of eliminating those foreign components. So that is what I tell them immunity is. As far as the question about sterile immunity, I don't know any examples where you can get sterile immunity with a vaccine. Now, you do get sterile immunity with an infection. So like if you're infected with influenza, usually you recover within a few weeks. And if you try to detect that virus a month later, you won't detect it because you've gotten rid of the virus. And so you have sterile immunity. But I don't know. Brian, do you know of any examples where?
Not really. Mary Ann, you were going to say something.
Yeah, I just was saying, can we clarify what does sterile immunity mean? So does it mean, what does that mean compared to when we talk about protective immunity? What are the two? What fundamentally, how do those things differ?
So I guess if I were to think of sterile immunity, I would think of you don't get infected. The virus or the pathogen, whatever it might be, it never gets a foothold. And that's again, I'm not aware of great details on that. I know Jeff, you probably have some to add there. Protective immunity is more what we expect more commonly. It's when the pathogen might get a little bit of a foothold, and you are protected against strong replication of the virus or the pathogen. You don't get very sick. You beat it off before it really gets too much of a foothold. When I like to think of immunity, I like to think of an immune response. I know that many folks think about immunity as you never get sick, but think about what we often hear every year with the flu virus or the flu vaccine is that, well, it may not be protective and you might still get the flu, but it might not just be as strong. That is typically what I think of as an immune response. You get a little bit of infection, depending upon the strength of your immune response, depending upon how well the vaccine matches the virus, you might not get very sick at all. You might not even notice it, but you might get, full-blown flu if it doesn't match completely.
Yeah, I think that's right. So I think of it more as it just stops you. If you have a good vaccine, it keeps you from getting sick, and potentially against the fatal infections, it keeps you from dying. So those are the kind of things that you want a vaccine to do, is really protect you from disease, not really protect you from infection. Because infections really is less relevant than disease.
Yeah, I think it's a really good point, because I think at least a lot of my friends and family, my non-scientist friends, think of it as the vaccine's going to make you immune and have sterile immunity, that you're no longer going to have that. And so, worrying about, well, if somebody got infected again, because I think there's a couple of cases now where we've shown people have gotten infected again, but in both cases, they didn't get sick. They just happened to be able to see the virus. So I think that is definitely an important point.
Yeah.
Do you have anything else on that you wanted to follow up on, Heidi?
Well, I was just going to say, I think, reading those cases about the folks who had the reinfection, I believe we've had one or two here in the States, and was it in China that there's been a reinfection, I believe. So if they didn't have the disease, how were they detected? How did they?
I feel like they were like a surveillance, but I can't remember the details exactly about those studies. I don't know. Jeff and Brian, do you remember?
My recollection is that a few cases where that's really been clearly identified is they actually were sick, I don't recall whether one was less sick the first time and more sick the second time. I don't remember those details, but I do think in the cases, and there have been very few of them, where it's conclusively been shown that people were ill to varying degrees. I think it's a good time to emphasize that one of the important things to keep in mind is everyone's immune system is different. This is one of the key things about our immune systems is we go through these processes of making, we've heard about these molecules, antibodies, and we mentioned T cells and other things. And our immune systems, my immune system is different than yours, Marianne. It's not simply just genetic backgrounds, but there's an element of randomness to every single person's immune response and the molecules and cells that make up their immune system. And that plays a role in the varying kind of responses that people can have to infection, to vaccines, and to this potential for reinfection and how sick you might get if it does happen.
So in some ways, these cases that we're hearing about this reinfection, it's kind of like those cases should be put in the bioarchives. We don't have a lot of information yet. This is the early information on these things. We can't draw any real conclusions from them yet because it's so new, right?
Yeah.
Okay, great.
Yeah, and I think, I remember sort of, at least for one patient, that they did get sicker the second time they were infected. But it's unclear how many of the 38 million people who have been infected got reinfected. You would anticipate that there's probably a very good margin or number of those, because we're talking in New York City, right? There were lots and lots of people infected. So the chances of them getting reinfected is probably fairly common or fairly prevalent. But you don't hear about those. And the only time you'd find out is if there's surveillance testing going on, right? And then they catch those people the first time around and then catch them again the second time around. So if they're asymptomatic the first time and they're reinfected and they're asymptomatic again, you probably won't detect them. And the reason we are detecting these individuals is because maybe they're the ones that are in audits. They're the ones that are getting sicker the second time around. And that's why we're here about it. But again, as Brian alluded, we don't have enough information about this to make a definitive answer.
Another question that's come up is this question about natural immunity. So when you naturally get over COVID and your immune system, and how it might differ with a vaccine. And so I thought maybe you guys could talk a little bit about what is a vaccine, and what vaccines are out there and being developed, and how might the immunity to a vaccine differ from the natural immunity.
Okay, that's a lot.
Well, Marianne does have in the pre-meeting materials and the other sort of things, you have a nice video of the various types of vaccines that are out there. So we can refer everyone to look at some of those videos for a lot of great detail on types of vaccines, RNA, DNA, whole virus, etc.
Okay, so we're done. Marianne, you've already done it for us. So
Yeah. No, but I guess what I'm wondering about is, so like we hear in some cases, especially about you mentioned it earlier, the coronaviruses that cause cold, and people get reinfected, and there's this idea out there that maybe the immunity isn't that strong. And so some people are arguing, well, then we won't be able to make a vaccine. And why is vaccine development maybe sometimes different than just the natural immunity?
Yeah, it's a really good question. And certainly there are differences between vaccines than a live infection. In part, I think that it depends on the type of vaccine that you're using. Are you using what we call a live vaccine, a live attenuated vaccine? So you're introducing the whole, say, virus, and so the immune response is against the whole virus? Or are you using just a particular component of that virus, and you're trying to develop a strong immune response against that component of the virus? And so you're going to get different types of immune response depending on which route you go. I would say that natural immunity, just by looking at other viruses, other bacteria, are usually give you longer lasting immunity than do vaccines. Just because of the strength of the immune response, the rigor of the immune response relative to. But as we talked about already, there are certainly examples of lifelong immunity with vaccines. And we're hoping to see that with the SARS, but we won't know until we actually have an effective vaccine and follow it over time. So I don't know that we can anticipate what this vaccine is going to work like, and also what the different types of SARS vaccines will look like as far as long-term immunity, and how that compares to a natural immunity until we actually are years away from that.
Actually, this is a great way to kind of circle back to one of the earlier points about EUAs, and this is the kind of thing that is often studied in vaccine development. How strong an immune response do you develop? How protective is it? How do you put the various vaccines head to head and see which ones elicit the best kind of immunity, and how does that compare to natural immunity that you might get from exposure to an actual live virus. And so these are some of the things that in this 4-year process that we alluded to in the early on that might be studied in great detail, and eventually we have a subset of really great vaccines that we can all rely on. And it's early, and I think it's fair to say we won't really know until, as people are saying, we won't know for sure until next summer at the very earliest, and probably longer. One of the things that differs between a vaccine, a traditional nowadays vaccine, a modern style vaccine that you hear about, Moderna and some of the other ones that are being developed, and infection with and recovery from a live virus. That is, you might become infected with SARS-CoV-2 and then have immunity there. Is the vaccine designer has to choose what kind of molecules to put in the vaccine. You've heard about antibodies, and antibodies get developed in response to molecules that are present either in the vaccine or on the virus. And the vaccine designer has to choose which molecules do I want to focus on? There's issues of ease of making it, expense and shipping and stability, and all those sort of real practical issues that we have to worry about. The less complicated the vaccine, the better for expense and stability and delivery and those sorts of things. So the vaccine designer, usually chooses one or two of those molecules that are part of the virus to use in a vaccine nowadays. Whereas an actual infection with the live virus, you got the whole virus and all of its gory pieces, and you can elicit antibodies and other types of immune molecules to all of those pieces of a virus in a natural infection. Whereas with the vaccine, you usually get one or two molecules that you get antibodies to. So those two types of immune responses, to focus the immune response to a modern vaccine versus a large, broader response against an entire virus, can lead to different lengths of immunity, different types of immunity, and how long you might have protection for.
Thank you very much. I think this is a great discussion, and it plays right into a bunch of questions from the audience that we're getting. And so I thought I would start by reading some of these. We probably won't get to them all in the time, but one in particular we have from Fran Greeny from Bethesda, Maryland. Fran, I guess it could be a man or a woman, I'm not sure. How does one measure the relative effectiveness of different types of vaccines? And would one more likely to be protected by taking a combination of different types? I thought that was an interesting question. What do you guys think of that?
So I don't know if you guys have talked about different parts of vaccine development. So there's preclinical, and then there's phase 1, phase 2, phase 3, and then distribution. So in the preclinical type time, what you're testing is usually animal models, and you're putting the vaccine into the animal, and then you're measuring really the immune response against the vaccine component. So in the case of SARS, you'd be measuring against the component of the SARS virus. And you can measure it in lots of different ways. Like Brian alluded, you can look at antibody responses, and there's this idea of T cells, look at T cell responses. You can look at what we call neutralizing antibodies. So antibodies that will neutralize the ability of the virus to infect the cell. So you're looking at all those components really in your preclinical studies to show how effective is your vaccine at blocking the ability of the virus to cause an infection and disease in an animal model. Okay. Then you go to the phase 1 and phase 2 clinical trials, which is really looking at safety issues. How safe, you look in the animals to show, of course, that it's safe in there, but you need to show how safe it is in the humans. And that's what you do in your phase 1 and phase 2 clinical trials. In phase 3, that's where you'd start looking at the efficacy and seeing if it blocks infection. But even in the phase 1 and phase 2 clinical trials, you're looking again at the antibody response, you're looking at sort of this T cell response, you're looking at whether you generate neutralizing antibody against the virus. All those things can be done using plasma and cells and things from your vaccinated patients. So you can determine how effective at least it is at inducing an immune response. How that translates to protection in humans, you don't really know until you do your phase 3 clinical trials.
Jeff, can I ask a follow-up question?
Mm-hmm.
Is it safe to participate in a vaccine trial? Or how do you determine that? How does somebody determine if it's safe for them to participate in a vaccine trial?
Yeah, I mean that's a personal, it's a personal judgment of that. Do they feel comfortable with the experts saying that based on all the data that we have up until this point, that vaccine is safe? So you look at safety in these pre-clinical studies. So if it's inducing some type of adverse response before you test it in humans. But it really depends on your comfort level. Personally, I would not have a problem with testing a vaccine that I know has been through those initial studies to show safety.
Let me, if I can just jump in on one issue there. I think many of us heard about the Oxford vaccine. Marianne, I forget exactly which one it is, but you mentioned it in your video, where an early, I think it was at phase 2, there's different subsets of phases. But one of the early phases of testing, it was halted due to some concerns about one of the study participants getting sick. This is exactly what you want. You don't want anyone to get sick, but this is what you want to look for in these early clinical trials, that enough people have been studied under enough conditions, enough dosage, et cetera, to identify any potential risks. That's the process of phase 1, phase 2, phase 3 trials that we allowed, hopefully can identify those sorts of things before they go out to the mass populations, et cetera. So that was a really good case study of a potential risk being identified in an early stage clinical trial of a vaccine candidate.
Yeah, I agree. And I have a really interesting question, I think a relevant one that it just came through, or actually it came, well, anyway, from James Wassel from San Mateo, California. And James asks, how long does immunity from the vaccine last? I'm guessing it is better to get higher neutralizing antibodies to the vaccine. What about cytotoxic T cells? So which vaccine should I use? Which one would give me the highest antibodies? What about 3 doses? Would 3 be better than 2?
James, you're speaking my language. Thank you for your question. So most vaccines nowadays are directed towards eliciting so-called neutralizing antibodies. Although some of the more complex whole virus, adenoviral vectors, other sorts of more complicated vaccines also lead to T cell responses. I think that as an immunologist, that breadth of response is probably what you really want to have. It's tough to really end, as much as I like your question, it's tough to really answer it directly because we just don't yet have the experience with these vaccines. Some of these vaccines that are designed to elicit solely elicit neutralizing antibodies are historically just fine and have turned out to be great vaccines for various viruses. Although, again, going back to the textbooks, having the breadth of immune response where you have neutralizing antibodies, you have T cells, you make the so-called memory T cells and memory B cells, et cetera. Generally, we expect those to be the kind of gold standard. But I think time will tell with all of these vaccines.
And I think that's one reason why having multiple vaccines already in phase 3 clinical trial. I think there are over 10 of them in phase 3 clinical trial, because we don't know which ones are going to be the most effective, which one's going to give the longest living immunity. So we're going to get that information as these phase 3 clinical trials are finished. And there you're getting 30,000, 40,000 people enrolled in these clinical trials, and the whole point of them is to say, how effective are they? Are they 50% effective? Or are they 60% effective? And so they have 2 groups. They have people who were sham vaccinated or vaccinated with their control, and then the ones with the vaccine that they're testing the effectiveness. And then they're looking for if there's a lower number of people who are who have disease in the ones that are vaccinated in your vaccinated group. And I think we're going to find probably among these 10, 12 vaccines that are being tested, there's going to be a range of efficacy. There's going to be a range of how effective they are. And I think the FDA has it has to be 50% effective in order for them to approve it. That's the minimum. But if it's 60, 70, 80% effective, the more effective it is, the more likely it will be used, by people in the research community and by physicians and such.
I also think it's important to emphasize real quick that over the history of vaccines are new vaccines come on, new vaccines are optimized, vaccines change. The vaccine you get for measles today is not the same one that was given 20 years ago. So the vaccine manufacturers are constantly adjusting. New vaccines come on for the same condition. You might think you're getting the measles vaccine, but it might be a completely different one than was given 20 years before. So that's going to happen here as well. These vaccines are going to be studied depending upon how well, looking 5 years out, how well these initial ones have done. Undoubtedly, we will probably have refined, updated versions, maybe altogether new variants of these vaccines.
Let me ask a follow-up question if I could, Marianne. I'm wondering about the differences that exist between the genders, ages, race, and ethnicity. Does the FDA account for these kinds of differences? Are there maybe minimum thresholds to enroll women of all ages, men of all ages, and then race, ethnicity, and so forth? Because as you pointed out, we have all of us have these different immune responses, and so if it works well for men, does it also mean it works well for women and across race and ethnicity?
Yeah, and I think that's why for phase 3 clinical trials, it's really important to have a large number of people enrolled, 30,000, 40,000, 50,000, because you want to cover the breadth of gender, race, all the different parameters, and you want enough numbers in the group to be able to see if it's effective or not against that particular group, like for example, gender. So that's you're wondering, when is a vaccine going to be out? And that's a hard question to address because you need to enroll enough people in a phase 3 clinical trial in order to tell whether it's effective or not. And getting people to enroll in a clinical trial, and as Brian mentioned, AstraZeneca has this one where they stopped it because of this potential complication they saw in their vaccinated individual. Now they've continued that, except in the U.S. for some reason, but that was stopped for a while, and that's of course slowed things down. So when we're going to have the information from the phase 3 clinical trial that tells us whether the vaccine is effective or not, it really depends on how quickly you enroll and how effective the vaccine is and whether you run into complications like what they had. We just don't know.
So I'd like to just switch gears a little bit because we're getting, thank you audience, we're getting tons and tons of questions. We're not going to be able to get to them all today. But this is a kind of a gear shift, and it's from Edward Kukla. I apologize if I've ruined your name. And Edward asks, immunity, or perhaps more precisely, an immune response can be a source of problems. If I remember correctly, the meningitis pathology can be caused by the immune system attacking the meninges, not the bacteria itself. Can this mechanism be a cause of COVID-19 pathology? And it made me think of this cytokine storm. And I thought, Jeff, maybe you could talk about that a little bit.
Yeah, that's a really interesting question. Inflammation is both a good thing and a bad thing. Too much inflammation leads to pathology, and too little inflammation leads perhaps not the ability to control an infection. So in the context of COVID-19, there is evidence to suggest that you're getting a hyper immune response and hyper-inflammatory response, and that's leading to some of the lung pathology and perhaps some of the pathology you see in the vascular system as well. So yes, I think the question is right on target in the sense that sure, that we can have an immune response that is the underlying cause of the pathology that is not, it's not directly due to the virus, but it's more a secondary effect because of the viral infection. I think that's certainly seems to be the case with COVID-19.
Actually, if I can add on that just a little bit, it seems to be in the cases of a very severe disease that you hear about. You hear about people getting sick and then they recover, but then there's a subset of folks who wind up extremely ill. The virus seems to, the immune response and its connection to inflammation, we haven't mentioned blood clotting, all of these things are very tightly connected. and they're very tightly regulated. As you know, the question kind of alluded to, dysregulation of any part of this immune response, whether it's inflammation, whether it's so-called cytokine storm, whether it's these other sort of things, dysregulation of that can be very deadly. And there is something about SARS-CoV-2 that in some cases leads to a very dysregulated immune response. And one result is a cytokine storm, which is sounds pretty sophisticated, but really it is a result of lots of molecules that are supposed to be made at very particular times in an immune response being made all at once and not under the kind of control that they need to be, and really an immune response gone haywire. There's something about the virus that can lead to that is unusual.
God,
Guys,
information. This is great.
this is really
Great.
awesome. I really appreciate it, but we're getting to the end. And so I think we really need to wrap up. And so I think this is our lightning round.
Let's do it. So Marianne and I thought it's just kind of fun to do like something quick and fun, and so our audience gets to know a different side of you. You're these scientists and have all this information, but we thought lightning round makes it a little fun. So you guys ready to go?
Sure.
All right.
Bring it on.
Don't sound so excited.
I know. So I'll go first, and then Marianne. And so Jeff, what is your superpower?
Handling a 15-year-old son. Yeah, that'd be a teenage son. That's certainly a superpower. I don't drink coffee, I guess. I'm one of the few scientists that can actually survive without drinking coffee and get through my day. So I do drink Coke, so I guess that's
Brian, what about you?
A superpower, sleeping 8 to 9 hours almost every night. It is absolutely has to happen no matter what. Okay, the kids aren't little anymore, so there was a time when that didn't happen, but for some reason that seems to be what I thrive on, and I make sure I do it as much as possible. Sleep.
Awesome. Okay, Brian, what's the last show you binged and loved?
Okay, so I don't binge watch anything. I don't really make the time to do that, but I'm really digging this show right now on HBO called Lovecraft Country. Which is this melding of, it takes place, it's based on a book from a few years ago. It's a melding of horror anthologies with the terror of racism in the 1960s. It's really fascinating. You watch the show, you watch these characters, and I won't give away the ending because I have read the book, but there's all this magical, monstrous kind of stuff going on. But what you take away from the end of the day, at the end of the book and in the series, is that that's all secondary to the horrors of racism in the 1960s.
Wow, that's a good tip. I'll definitely watch it. Jeff, what about you?
Game of Thrones. I mean, I really didn't know anything about the show, and I was riding on a plane, and there was a Time magazine, and they had an article about it, and you know, it was like almost all the way through the, I don't know how many seasons there were, 6 or 7. And then I said, man, this sounds pretty cool. And once I started watching, it's a lot of time, but I finished it in probably a month. So.
Well, I think that finishes like in the top 10 of like the most popular right now or something like that. So it's popular. Jeff, what's your most treasured possession?
I don't really have a lot of possessions. Maybe I do have an autographed bat and ball from Hank Aaron.
Oh.
So I would probably
unusual.
take that with me if
Yeah.
the house was burning. Besides my family and dog, maybe that's what I would take. I also have a Porsche 944 Turbo Classic, so maybe we'd all drive away in that. But
That's right.
Those are things.
Brian, how about you? Treasured possession.
Okay, so setting aside, you know, kid mementos and photo albums and those sort of things, I take a pair of drumsticks everywhere I go.
Oh.
Nice.
Here, so that's my other life. So I don't leave home without them.
Awesome.
Okay, Brian, what's your favorite meal?
My favorite meal. I'm a sucker for Mexican food, any kind of Mexican food, just, you know, cheese and sauce and chicken or beef, whatever, lay it on. Take all those ingredients, mix them up in 100 different ways. It's all great.
Jeff, how about you?
You know, I don't have any Italian blood in me, but boy, I love Italian food. So you can give me anything Italian, I'll probably eat it.
I will jump to our last one. Jeff, what are you deeply grateful for right now?
I would say just being healthy, for friends and family. There's so many people who have been touched by COVID-19, and knock on wood, we've had people stay healthy, especially, you know, my father and Kristen's parents, because they're, of course, the most susceptible.
Brian?
Well, it's hard to argue with that. It's also, I think, important to recognize that, you know, the pandemic has not really just hit people's health. It's hit people's well-being and, you know, financial well-being and jobs and other things. And so certainly grateful for being able to, you know, to be in this position. But I think just pivoting a little bit, you know, we've come such a long way in understanding this virus and developing therapies and where we are in a vaccine. So I'm tremendously grateful for all the investments in science over the years that have got us to this point. You know, we first started hearing about this virus in January. I mean, it wasn't until 3 weeks or 4 weeks later that we had the genome, and then all of these various other things just snowballed. And so to think where we are right now, I know it's a scary time, it still is, and but to think where we are right now in terms of being close to having a vaccine and having some treatments, some not even experimental anymore, it's just remarkable, and it builds upon this great investment that has been made both in people as well as science and the whole enterprise we have to be able to get to where we are right now, and hopefully, you know, beating this thing.
You guys, that was really awesome. I've known you for 20 years, and I feel like there's a lot I didn't know about you. You know, on behalf of Heidi and I, and plus all of the participants, I just so appreciated you being on and having this conversation. It was definitely fabulous. And to everyone else, I want to remind you about next week. We'll be talking about public health and masks and social distancing. Our guests will be Mark Fox, the St. Joe Deputy Health Officer, and 2 professors from engineering who have tested some masks. And so please join us again next week, and consider this: the more you know, the more good you can do.
So be informed and act on accurate information.
And pass on reliable information to others.
And until next week, be kind and give grace to each other. Bye-bye. Thank you,
Bye.
guys.
Thank you.
Bye, everyone.
Bye-bye.
You still there?
Yeah, I think we're still recording though.
Okay.